presented to the portfolio committee on our vision for NHI and for NHI during the transition period. All our strategies align to the fact that we provide access to high quality, patient-centered. Often the patient-centered aspect of pathology services is not focused on, but we want to make sure that it is focused on. We provide one of the most cost-effective service in the whole country. Our prices as compared to the private sector are extremely low, and we're continuously reviewing this in order to provide cost-effective services. We've got to focus on innovation and new technology to improve efficiency. We're investing in information technology. Digital technology is also another key project for us, as well as improving on logistical services to improve efficiency. We're building capacity in the workforce and in our various sections in order to ensure that we've got efficiency. We've got a number of partnerships, both nationally and internationally, in order to take forward our mandate. Our information management system is one of the best in the country, and internationally we compete very well with our central data warehouse. And we've mentioned this before, that COVID-19 has shown how efficient we are with the production of reports, because there hasn't been a single day in the last 3 years where we haven't managed to provide information on COVID-19. And the focus for us is around communicable and non-communicable diseases, both prevention and surveillance for both the provincial and the national governments. Our strategic priorities that are linked to those priorities that I've just mentioned is achieving clinical effectiveness and efficiency by implementing the order entry system. One of the challenges that we faced previously was that there isn't an interface between the lab information system and the hospital information systems. And we are now trying to implement a system where the clinic interfaces and the hospitals will interface directly with our lab information system with regards to the capturing of what tests needs to be done. And in this way, we'll also be able to track the time that it takes to come from the clinic through to our laboratories. A key focus is building capacity in the workforce. I've spoken about new technology and transport logistics. Working closely together with the National Department of Health, we are looking at implementing the HPRS, the health patient record system, so that we've got a consistent, unique identifier. A major focus is the automation of our processes so that we can improve the turnaround times and throughput. We also want to create a seamless service by implementing phlebotomy services so that the quality of our specimens that we receive in our laboratories is much better. Accreditation is a key aspect for national health insurance. So we're making a very concerted effort to look at getting all our facilities accredited, and I'm pleased to say that we've increased the number of facilities that have been accredited. So we've got all of our national central laboratories that are accredited. We got 15 out of our 17 provincial tertiary laboratories. 32 out of our 45 regional laboratories are accredited. And our major focus is going to be on dramatically improving on the accreditation of our district laboratories, as this is where the gap is. I've already mentioned that going forward, research and innovation is going to be an important aspect. We're already internationally renowned for our research that is done through our various institutes, as well as the NHLS, and this we will strengthen. The chair has already spoken about the fact that we've recognized that we will be having financial challenges going forward because of the decreasing provincial budgets in the public sector. And we know that this is going to put a squeeze on the laboratory services. Looking at how we can enhance our revenue and looking at alternative streams of revenue is going to be quite important for us going forward. We've already started embarking on some of those services, such as public laboratories with regards to infection control. And so there's a number of strategies that we are looking at. The rising costs for both personnel expenditure and goods and services and equipment is going to exacerbate some of these challenges. And as I've said, we've developed a revenue enhancement strategy so that we can just make sure that our financial stability that we've created over the last 5 years will continue into the future. We are continuously then also looking at the overall costs of the services in order to look at how best we can make sure that we provide cost-effective services in order to assist the provinces so that the burden on them would not be that great. We've also done quite a bit of analysis on the private sector, and we work continuously with the Competition Commission in order to look at the prices within the pathology sector. So Chair, then just quickly to run through the annual performance plan and our key performance indicators. Chair, I hope you're still here because we've just been load shedded. Okay, but our power's kicked in again.
Thank you very much. Yes, we can still hear you. Let's do our best in the time before we lose you, maybe. Thanks.
Okay, so Chair, just to say that we've done a very extensive situational analysis, looking at the legislative policy changes, looking at social factors, the burden of disease, etc., etc. And then both the internal and external factors. I'm not going to go through all of those details, Chair. It's within our strategic plan. We've looked at the economic factors. We've looked at technology, international trends, the environmental trends as well. One of the key issues, as the Chair has pointed out, is our the stability with regards to the power issues and load shedding. And I need to point out, Chair, that we have written to the municipalities as well as ESCOM, and we're having discussions with the National Department of Health to see in what way we could be exempted from the load shedding, because every time that there is load shedding, it creates enormous problems with our equipment, because the continuous cutting off of power impacts on the tests that we run, as well as on the antivenom, because if the power gets interrupted, we need a continuous 8-hour supply of power, and when it cuts out, it impacts on our productivity and on the quality of the specimens. So we have asked that we get exempted, but we're also going all out now on a solar project in order to get solar power at a number of our facilities. It also impacts on our lab information system, because it's with continuous power outages, our systems go down. So this is an issue that we are looking at. Chair, we've gone through an extensive SWOT analysis, and I'm not going to go through all of the details. We looked at what our strengths, weaknesses, opportunities, and threats are, and this all then relates to the KPIs that we've looked at. Just to quickly then run through the budget. So the audited financial statements for 2020-2021 was 11.7 billion, which is what we got from our revenue. The majority, and then it was 12.8 billion in 21-22. The forecast for 22-23, we'll only get the audited financial statements at the in October, but it's 13.1 billion for the revenue. So for 2023-24, we have added on we budgeted for our total revenue at 13.5 billion. That increases to 14.3 and 15, which we of course will review for the NTF period. Our test, the majority of our revenue comes from our test revenue. We also then get a small amount that comes from donor funding and other sources. There's a small amount from the private sector. We've got a very careful investment strategy, and from that we receive our interest of our forecast was 221 in the financial year for 2022-2023. The transfers, Chair, are the conditional grants that we get from the National Department of Health and Treasury, and these conditional grants have been decreased. So the two conditional grants that we get is for teaching, training, and research, which comes directly to the NHLS. We also then receive a grant for the NICD, the National Institute for Communicable Diseases, and we receive a grant for the NIOH. The grant has been cut for all three of those, and you can see that it decreased between 2020-2021. It went from 758 to 640. It increased our forecast again, it has increased for 2022-2023, but that increase has been because the forensic chemistry laboratories, their conditional grant has been added. So in actual fact, there's been a 10% decrease in the conditional grants on average for the next financial year. We are quite concerned about that because that's got implications for the PISA going forward, because we are subsidizing both the NIOH and the NICD with almost twice the amount that we receive in the conditional grant with funds from the NHLS. We are continuously meeting with Treasury to try to advocate for extra funds for these institutes. Our budget for compensation of employees, the forecast was 5.3 billion, and we have budgeted 5.9 billion for the 2023-2024. Goods and services, the forecast is 7.4, and we've budgeted 7.5, so it's a small increase that we've done for goods and services. Our expenditure, we are estimating it to be about 13.4 for 23-24. The forecast for this year is about 12.7 billion. So we're estimating a small surplus for 23-24. The unaudited surplus for the forecast 22-23 is 437 million. Chair, to then quickly run through the programs. The first program one is laboratory services. Our key focus there is to ensure that our turnaround times for a number of the key tests and this is what we've also discussed with the provinces, are within an acceptable turnaround time. I'm not going to go through all of the details, but we've looked at the turnaround time for the TB tests, for the CD4 tests, as well as the viral load tests, and all the HIV, all the priority programs. We've included now the cervical smear screening as well, full blood counts, and urea and electrolytes. We've looked at what the audited forecasts are and the planned performance, and we've looked at and we've tried to look at improvement in all of the estimated performance. Chair, just to say that whilst we've got turnaround times of for example, CD4 within 40 hours. We strive to come within that turnaround time. And our in-hospital turnaround times is much better than our out-of-hospital turnaround times. And we've got a lot of detail in sort of analyzing that. We added the SARS-CoV-2 PCR test, which is a new one. But we know that these tests will be increasing in the coming financial year. A key focus for us is point of care testing. We had developed a plan. We're now implementing a pilot, and we are assessing the pilot for point of care. We also, as I've mentioned, is looking at we've got a digital pathology plan, and we are preparing for the implementation of digital pathology, which is going to be extremely important for innovation, because with digital pathology, we will be able to load a slide, for example, for histology in Charlotte Mtreke, and somebody will be able to read it in Nkosi Albert Lutuli, and we'll be able to use that for also teaching and training purposes. I've gone through the detail. I've spoken about the accreditation system. So for program 2, it's academic affairs, research and quality, and the key performance area is strengthening the total quality management systems. We'll be doing this through the annual quality compliance audits. We'll also be doing it through the proficiency testing schemes. We've got what our targets are for that, and we've tried to improve on the targets. Then we've looked at the number of facilities that will at the central laboratories, provincial, tertiary, regional, and district laboratories that we're looking at accrediting or maintaining accreditation. And we've given you the details with regard to that. You can see that we're aiming to do all of the provincial tertiary laboratories, all 17 of them. We're increasing the number of regional laboratories as well as the number of district laboratories. And then we're also looking at ISO 9001 certified departments and increasing those number of departments. One of the other outputs with academic affairs is ensuring equitable coverage through getting pathologists to cover the facilities where there are no pathologists. We've given you the indicators for that. With regard to publications, we had our numbers that were audited was very high during COVID. We produced a number of COVID papers, but we are looking at improving it from the last financial year. And then the other aspect is the training of both registrars and intern medical scientists. And we're looking at improving, maintaining the number of registrars and medical scientists that we will train. With the program 3, it's the NICD and the surveillance. Our KPIs there is the diseases under surveillance, our notifiable medical conditions that we respond to immediately, the number of NICD laboratories that are accredited, and then the HIV surveillance reporting and TB surveillance reporting. Both of those are new, and we've got some targets that are quite robust, that we're confident we'll be able to achieve. NICD also has a number of peer-reviewed articles that will be published. And again, the number has dropped because of the number of COVID articles, but it's still there's an improvement in our targets. And then we also train field epidemiologists, and our intention is to ensure that we train about 8 field epidemiologists for most of the provinces. The next program is for National Institute for Occupational and Environmental Health. And there we've got targets for the number of occupational health laboratory tests which are conducted within the predefined turnaround time, the number of occupational health and environmental health and safety assessments that are completed, the occupational health surveillance reports that we produced, and the number of NIOH laboratories that are SANAS accredited. Our intention is to make sure that all of them are accredited. The forensic chemistry lab, as we've indicated, they just came into the NHLS. We did look at what the previous KPIs are, and we've given you new KPIs. So we're looking at the number of blood alcohol tests completed within a normative period of 90 days, the reduction in the number of toxicology cases, and we've got major challenges with regard to this, but we are busy working with the South African Police Services as well as with the forensic pathology services in order to address some of the backlogs in the toxicology cases. We're also looking at opening up new facilities. We're busy in the process of relocating the facilities from Pretoria because they've been working under extremely cramped conditions, so that we can expand on these services. And then we're looking at the perishable food samples tested within 30 days of sampling, as well as the non-perishable food samples tested within 60 days of sampling. Chair, with regard to program 6, which is administration, the first sub-program is on finance. The KPI there is we're looking at our current assets to current liabilities of 3.8 to 1. We're going to reduce that to 2 to 1. Our cash flow, as I've indicated, it's improved quite dramatically as compared to 5 years ago. Our creditors' days, we have reduced it to bring it in line with the PFMA to 30 days. And our debtors' days, we brought it down to 120 days, Chair. As we've indicated that some of the provinces are starting to struggle with the payment of the debt. This is something that we are addressing, but we think 120 days is realistic. We have created a new KPI around affordable pathology services, and we are reviewing the top 100 pathology tests by volume over the next 4 years. We're looking at recosting of those tests so that we can look at continuously look at affordability issues for the provinces. The chair has spoken about the challenges within supply chain. We've broken down the tenders now that are below 10 million because that we believe can go a lot faster. And then the tenders above 10 million, we've created that as a new KPI, we're looking at within 180 days of turning these tenders around. With regard to modernized information technology services, we've created a new KPI on our bandwidth rollout in order to improve on our infrastructure for the multi-protocol layering system, our NPLS. We've created a new KPI for the distribution of our reports to provinces from the central data warehouse, so that all public hospitals receive the monthly report on all the tests that are done, who does the tests, turnaround times, etc. We've also, as part of this program, included a stock management system and analytics that we'll roll out to all our provinces. And we've looked at the percentage uptime for a number of our critical systems as a KPI. For human resources, we've looked at our staff turnover ratio. There's always been a sort of an average 5%, and we're going to try to maintain that. put in the number of intern medical technologists and medical technicians that we will train in the NHLS, the number of employees we will train as part of the workplace skills plan. That's a new indicator that we've put in, and the number of employees that we'll have with approved and evaluated performance agreements. Chair, then just to quickly summarize, these are the changes that we've, the portfolio committee needs to be informed of the changes that we've made to the strategic plan. So we changed what was the output, we've changed the wording to improve oversight and access to pathology through technology and innovation. Because the previous one that we have has very broad and modernized laboratory services. So we decided to just narrow it down. We've changed the output for forensic chemistry to keep it in line with our other outputs on improved turnaround times, because we think that's a key performance indicator for forensic pathology, for forensic chemistry. We changed the issue around cost-effective services, because we thought that it's more important that our outputters provide affordable services, and that we look at reducing the cost of pathology services through the reviewing the costs of our top 100 tests. And then around good governance, we put the output as a percentage of RFQs awarded to service providers that have a BEE rating of score level 4, in order to comply with some of the legislation. So Chair, those are the changes that we've made to the APP. And Chair, I will stop here, because I'm sure that there are a number of questions that the portfolio committee would like to ask. Thank you very much. Chair, also just to say, sorry, I didn't introduce the executive team, but I think there's too many people in the room. But we've got the executive management team from the NHLS. We have apologies from Professor Malasana, who could not attend as she's unfortunately off sick, and she but maybe just to introduce a newly appointed Chief of Operations, Dr. Clotilde Oliphant, Chief of Operations for Strategic Initiatives, who's been appointed in the beginning of February. So she's joined our team, and we've also the newly appointed Chief Financial Officer, who was acting, and the portfolio committee will know her, but she's been appointed now as full-time Chief Financial Officer, Ms. Pumeza Naikiso, who's also here, for Adrian. And then we also have Professor Adrian Purin, who's the Director for NICD, Dr. Spo Kalamono, who's the Director for the NIOH, and we've got the HR Executive, Mahopelen Mponazi, and we've got Advocate Paul Mpelo, who's the Company Secretary, and we've got Mr. Sibongi Seni Shlangwane, who's the IT Executive, and we've got Ms. Babaki, who is standing in for Professor Malasana as the upper executive. Thank you, Chair.
Thank you very much, Dr. Chetty, for the presentation. Honorable members, I see only 2 hands based on the platform. Anyone else? So I'll take Honorables Clark, Yela, Chirwa, Wilson, and Kaba.
Sorry, and myself too, Chair.
Makwayo.
Can I start, Chair?
Yes, you may. Thank you.
Thank you, Chair, and thank you to the NHLS for the presentation. Just a couple of questions. Dr. Brookett said in the beginning that there is no shortage of snake venom. Can you please then explain to us that during last week, a man from Noordhoek in the Western Cape was bitten by a cobra, Cape cobra, and they could not source any anti-venom for that case. And the African Snakebite Institute have also acknowledged that they're really battling to find snake venom and that there's a shortage of snake venom in this country. So if I could just get clarity on that. Then last year, there were media reports that changing to the new service provider, Zamalingeni Holdings, caused disruptions to the services. Can you please give us an update on that situation? And then what is the deadline to ensure that all laboratories are accredited? Are these labs that were denied accreditation? And if so, how many and what were the reasons why they were denied? And then what are the alternative sources of revenue that have been identified and how much income are they projected to provide? And then could you please explain if you do have any backlogs and what are those backlogs? Then I've also noted that your HIV PCR tests have dropped from 90% in 2021 to 81% for 22-23. And what is the reason for that? And then what is the time frame to address backlog on toxicology and blood alcohol testing as this has a huge influence on prosecuting these cases? And then I note that medical technologists and student technicians are being trained. On the slide, it said there were 250 of those for 22-23. Can you please advise me what happens after the training has been finalized? Where are these students placed? Thank you.
Thank you very much, Chairperson, for the opportunity. Let me also welcome the presentation from the NHLS, Dr. Chetty. Chair, I think I fully support the proposal that they must be exempted because of the work that they are doing and the tests that they are performing. The load shedding is also affecting them seriously, Chair, as we know that we are experiencing a load shedding in our country. But Chair, I just want to ask, how has the entity dealt with the challenges such as aging infrastructure, the IT skills shortage? That will be my first question, Chair. But also, can we also get the update as the portfolio committee on the outstanding of non-payment 5.89 billion by the provincial health departments, of which 4.17 billion was owned over 90 days. If we can just get an update on this issue. But also the other question, Chair, to also get a clarity, or if they can also explain the plan to carry the deficit of 368.5 million for the conditional grants from the National Department of Health. My other question, Chair, it's related to forensic chemistry laboratories, Chair. The integration of the FCL present significant challenges. The NHLS chair, if we can also get clarity, the sustainability, what is the progress and the challenges being faced. The other one, Chair, it's regarding to what is the entity understanding of a zero progress on regulation for NAPISA. If we can get explanation in detail, the impact this has on the NHLS and the intervention required from this committee. The other one, Chair, the last one has been touched by the latter speaker, Honorable my colleague, but I also want to emphasize because it's talking about a very sensitive matter. I just want to check what were the issues leading to lower turnaround times on HIV PCR test, and what intervention will be put in place to achieve a 2023 and 2024 financial year. I will pause the chair. Thank you.
Thank you very much, Chairperson, and thank you to the NHLS for their presentation as well. I want to follow up on the two media reports, these two particular media reports in this sense. The first one is about the approval of the 60 Mercedes Sprinter buses that were converted into mobile clinics, costing in excess of 65 million rand, allegedly without a proper plan to resource them. If the NHLS is able to appraise us on this particular matter. And secondly, the issue of the Zamlangeni holdings. Firstly, in relation to that, how many health facilities were affected by the issue of delay of collection of medical samples following the appointment of Zamlangeni Holdings as the new new delivery service provider of the NHLS? And second to that, what did the NHLS do in response when this crisis was flagged and was raised to the NHLS? Because I don't see any response on the part of the NHLS that is captured through a press media statement. The NHLS hasn't responded to this issue. And thirdly, why has the NHLS not gone through a process, firstly, of increasing the capacity of the NHLS on services that they will always be using through insourcing? And I think we have this conversation every single year. Please don't cite the issue of the security guards or the cleaners being insourced. I'm asking about this particular one. What is the reason why you haven't increased the capacity? Because you will always need delivery services as the NHLS. And you shouldn't be tendering this particular system. It's one of the core duties or obligations or mandates of the NHLS in getting the NHLS mandate to be done. Why have you not increased your internal capacity on this particular thing? Why is it still a tendering system? Because it's just a vital duty of the NHLS. And lastly, on this particular issue, what is the current status of this issue right now? And thirdly, in the last committee meeting where you were presenting to us, we raised issues of racism and sexism in the entity. I want to know what the NHLS has done following us raising those concerns of racism and sexism in the entity. And I'm raising this because particularly I was very unhappy with how you dealt with the Mposeleka case, that it was strongly tied to racism, because even though in the CCMA settlement, for example, the NHLS, you agreed to not that you will not give adverse reference against Mposeleka or anyone or potential employer, and yet you still blocked her from getting a government scholarship co-hosted by the Department of Health and NICD, right? Which she was shortlisted for. She was told the night before, and I've raised it even the previous one. So I'm asking this not from anything, but because there's a basis on how you guys have been so harsh and intolerant on this particular Black woman. And I know the tolerance level would have been 10 times higher if she was a white man. So I'm asking, what have you done to address issues of racism and sexism in the entity? There's no place for that kind of intolerance, or for that kind of, a lack of proper consequence management, or dealing with your employees properly if there's any conflict or stuff like that. You were very intolerant in the case of Mposilika, and you don't have to defend yourselves on this particular thing. I read the response you sent to me through the chairperson of the portfolio committee, and it still doesn't amount to how you guys have treated this particular person. So I'm asking about the racism and sexism and what you are doing to do tangible transformation in the entity. There's no space for that kind of behavior, honestly, in a government entity post-apartheid in South Africa. And if you're unable to do these kinds of changes, please evacuate. Then you're not the right people to be leading this entity. And lastly, on the anti-venom issue, I know my colleagues have touched on this, but I'm particularly worried about who is lying. I feel like somebody's being dishonest with the public. I don't know if we are being misled as the portfolio committee, or if the Minister of Health was misleading the nation when he told the nation that there is absolutely no issue with deliveries and all of those things, and that the NHLS is saying that load shedding is an issue and affected this. What is the truth here? Do we have an anti-venom issue or do we not? And also, in addition to that, there can be a tangible, it's such a small industry where experts are involved, right? Where there's 27 stakeholders who are saying we have this particular crisis in the country. And then the minister says, no, we don't. There's absolutely no issue with deliveries or any of that thing. And then NHLS says there's no issue, but then you cite in the load shedding, without any precise or concise deliberation on that particular issue. What exactly is the truth, guys? Because now, if you are telling us about load shedding in portfolio committee meeting, it means the minister lied. It means the minister lied last week when he said there are no problem, there's no issue, there's never been an issue, and there's no issue with delivering, there's no issue with generating, there is no anti-venom issue. That is what the minister said in public. But you guys today are telling us about load shedding. What is the truth? And load shedding was there last week. Load shedding has been there. Load shedding is a crisis. We're on stage 8 right now. So it can't be a thing that you realized last night, that load shedding is the issue, or that it had a problem with, keeping, or whatever you guys have just said in this particular meeting. What is the truth? Can we just get the truth? Because now I'm confused. And I'm very close to assuming that the minister misled the country and lied to the country because of what you presented in this portfolio committee, and also because of what numerous experts and stakeholders have been saying about the anti-venom crisis. Thank you, Chairperson.
Honorable Wilson, please unmute yourself.
Sorry, Chairperson. I hope I'm audible. We have a truck working just outside the premises here.
We have lost you, Honorable Wilson. Yes, you're gone. Honorable Kaba.
Thank
Honorable
you, Chair.
Thank you.
Yes, thank you, Chair. Chair, I think I'm joining Honorable Gela in welcoming the presentation. Indeed, we do support that they be exempted. For us, health is a critical matter in all aspects that relates to it, which really the matter of literacy has to be a thing of the past. But for me, Chair, it will be the following question: how many SNAS laboratories are there, and what is the percentage in terms of accreditation? I think that is important if they will really share with the portfolio on that matter. Thank you, Chair.
Thank you very much, honorable members. Honorable Wilson, are you back? No. Yes, Honorable Wilson, please continue.
Thank you, Chairperson. I got hit by the dreaded load shedding. and had to change devices very quickly. So I was discussing the NAPISA bill. It was passed through Parliament in February 2020 and was signed off by the President on the 5th of August in 2020. And yet it appears not to have been proclaimed, and perhaps Professor Book or Dr. Chetty can give us some indication what the holdup is and why this is not happening. It's something we need to obviously follow up. My next concern is the payment levels by the provinces. And this is a situation that's not going to improve. In fact, given the current situation, I think it's going to get drastically worse. The current financial situation of provinces, and we are still awaiting the provinces' reports, appear to be very, very unstable, with massive accruals and lack of funding due to medico-legal claims, putting them under strain. And obviously the bulk of your revenue is coming from those provinces, and it is already indicative that some of the provinces are not maintaining their agreement levels and stretching out as far as 90 days. I may have missed it, but if we could get a document, please, that highlights exactly what each province owes, how long they've been outstanding, and what agreements they have made with you to bring this up to date. Because if this doesn't happen, we're going to have a crash in the NHLS as well as everything else that we're experiencing crashing around our ears at the moment. You talk about the accreditation of laboratories. Now, exactly who does the accreditation of the laboratories? We had a presentation yesterday by the OHSC, who have a severe strain to do investigations, inspections, and accreditations. And the bill clearly states that those people who are not accredited, I'm talking about the NH bill, who are not accredited, cannot form part of the National Health Insurance Bill. And if we've got lots of laboratories that are not accredited, we're going to hit a big wall when it comes to that. And then just finally, and while some of us know the answers to this, a lot of the public don't, and it creates huge confusion as to exactly which forensic laboratories were taken over by the NHLS. Now, we know it was the forensic chemistry laboratories. Can you just highlight for everybody on this system, please? What is the difference between forensic chemistry laboratories and other forensic laboratories? We get a huge amount of complaints with regards to laboratories, particularly forensic laboratories, some of which fall under SAPS and some of which fall under NHLS. If you could just clarify those for us, please. Thank you, Chairperson.
Thank you very much, honorable members. Dr. Chetty, I have a number of points I want to raise with you.
Sorry, Chairperson. I think
yes, Dr.
I'm supposed to speak before you. Thank you, and thanks for the presentation done. I have only two questions that I would like to ask the committee. When they were presenting matters pertaining to the strategic priorities, mention was made that they have an effective and efficient IT, digital technology and communication, etc. But my question is, if their information vessels, the aging of IT infrastructure and coupled with the load shedding, as we are experiencing it today, how do they deal with the clinics which are experiencing aging IT infrastructure and load shedding? Because they said there are interlinks that are created there, but we have the majority of clinics definitely that are undergoing problems pertaining to aging infrastructure, and we can't even talk about load shedding because we are all affected by that. And the last question is, how is NHLS dealing with the limitation posed by Protection of Personal Information Act in conducting its surveillance? Thank you, Chair.
Thank you very much. Firstly, Dr. Chetty and Prof. Buch, it's commendable that you're looking at alternatives for the load shedding challenge. I think, firstly, we understand that we had not had the level of load shedding before. And secondly, we understand that the different tests take certain periods of time in order for a test result to be considered to be correct and applicable to the person, whatever was tested. So we also understand that there's a time frame for the run of tests. Some would take minutes, some would take 30 minutes, some would take even a few hours. So I'm just trying to understand from you how many of these tests can take quite long. How do you plan in terms of the load shedding schedule? And I know it's a difficult question because some of these are being done at hospitals, some are done at laboratories which are off-site from hospitals. There's transport involved. Quite a bit of us who in the medical field, we understand the challenges. So I'm actually trying to say that none of this is really because of your doing, but it's also commendable that you're looking at solar power generation. Because South Africa has a lot of sun power, solar power, and we should really be looking at those renewable energy alternatives. So I appreciate you actually looking at that as a matter of urgency. And then secondly, your human resources training of new personnel. I asked the same question yesterday to the OHSC. What is the accreditation process? Are they SAHPRA accredited? Does it allow those who are trained to have a particular qualification, whether those are diplomas, certificates, etc.? And what are the opportunities for career advancement of those people who undergo this training? And then what also would be the demographics of those people whom you send for training or have trained to work in the field, say the epidemiology field or any other field? How does it really benefit them? How does it benefit NHLS, and how does it benefit South Africa? And then shortly, if you could explain shortly your mandate in terms of funding for the NICD, the NIOH, the Forensic Chemistry Laboratory, the National Cancer Registry, whether these are funded, unfunded mandates, how does it impact upon you doing your work? Because I also note a decrease in the conditional grants to yourselves. And if you can maybe just shortly tell us how, when we do look at our report, in terms of our recommendations, what you think those ought to be. So thank you very much, Dr. Chetty. I'm going to hand back to you and Prof. Buch, and also welcome to your executive management team whom you have mentioned. Please continue.
Thanks very much, Dr. Jacobs. There are not too many broader governance questions. I think most of them are for the CEO to answer at the executive operational level. But let me just pick up on a few of them. So on the question of snake venom, just to be clear, there is a problem that we have had reduced production, and there's a strategy in place that the CEO can articulate to deal with that. And certainly as a chair of the board, I'm happy that we're getting on top of the problem. But the separate point is that the impression that has been given in the press is that there's no snake antivenom in the country, and therefore anyone who gets bitten will not be able to get snake antivenom. And what I was pointing out is that production did not stop completely, and that we have delivered antivenom to over 100 facilities around the country in this year, in this calendar year. And therefore there is if someone does get bitten, they should be able to access snake antivenom from one of those facilities, largely public and private hospitals that have snake antivenom. And to this effect, we're putting in place an emergency number which people will be able to contact to be able to be guided to where that antivenom can be procured close to where they are. So I just, what I'm saying is that I was trying to balance this perspective that there's no production and there's no antivenom, and that is not correct. Then in terms of the question of NHPSA and the conditional grants, my board has supported us tapping into our reserves to cover the shortfall, so that we are able to hand over to NHPSA a fully functioning, fully operational, full capacity NICD, NIOH, and the other entities. So we are committed to the role they play for the country and to handing them over in the best possible circumstances. Once NHPSA is established and it has its own board, then it is no longer part of the NHLS, and they would then be dependent on the conditional grant and any other funds that the board or the entities that make up NHPSA are able to get. So that's where we are. In terms of the implementation of the NHPSA Act and when it comes into being, that is not a matter that the NHLS board has control over. That matter sits with the Minister of Health. So we are not in a position to sort of really answer for the minister on when regulations will be issued and so on. In terms of provincial payments, there are challenges, and some provinces have started to lag a little bit more than before. But I think on the whole, we need to really appreciate the commitment of the provinces to paying the NHLS bills in spite of any other challenges they have. So although they may not be paying the full amount this year, they may be paying this year towards last year. And broadly speaking, many or most of the provinces are sort of paying us in this year more or less getting towards what we billed for the year. So even though some of it goes against accrued debt and some of it current debt, and so yes, I'm not saying there isn't a problem, and I'm not saying some provinces are not behind, but I think we also need to acknowledge the efforts that provinces are making to meet the commitments to paying the NHLS. And the CEO can talk to the very active engagement she has with the provinces in following up on payments and the very positive relationships that are established with most provinces. In terms of POPIA, we are POPIA compliant. We spent extensive time looking at the legislation, looking at confidentiality and all the processes that go with POPIA. Remembering, for example, that you may have a patient who is HIV or TB positive, either a new case or a person whose treatment is no longer working, or they may have defaulted and need follow-up. And there, the name has to go to that patient's, what's in legal terms, their treatment circle, who needs to be able to find them and identify them and try and encourage them and enable them to return to treatment, both for their own good health, as well as if they're not able to continue to spread infections, especially to those close to them and to the community. So So we've done a lot of work on POPIA, and we are compliant. In terms of the question on training, just to emphasize that we have two, if you like, legal responsibilities. The one is in terms of the NHLS Act, where we provide the training platform for pathologists, laboratory technologists that are trained in the universities and University of Technology, and we partner with them providing the training platform, which includes the payment of the academic pathologists, as well as bursaries that we offer to technologists. When it comes to labor legislation, we are very committed to staff development. We have a training institute, and we invest extensively in the development of our own staff. And then the other question was the question of insourcing, and I'm sorry, honourable member, but we struggle to hear you a little bit at times, and my understanding of your question was around insourcing. My board was committed some years back to insourcing. We reached an agreement with our unions on insourcing the services you referred to, and we accelerated
Point of order, Chairperson.
the process. So we have insourced.
Point of order, Chairperson.
Honorable Chirwa, can you let him finish, please? You can come back and
No,
raise
he's
the
not
point.
answering
It's
the
not a
right
point.
question. It's a point of order.
Yes, but
Can
you
you
can
just
raise
take
it afterwards. It's not really a point of order.
Chairperson, it's a point of order. You don't know what I'm going to say. I'm raising a point of order as a member of parliament.
Honorable Chirwa, I'm the chairperson. I am not. You already said what your point of order is.
You don't
I'm
know.
saying
I
it
haven't
is
said
not,
my
but I'm
point
going
of
to give you
order.
an opportunity later. I'm going to let you ask your question,
great.
but let him finish his reply. Thank you. Please continue, Professor Bu.
Great. Thank you, Chair. That was my last point from a governance perspective. I'm handing over to Dr. Chetty to take the rest of the questions, which are in her domain.
Thank you very much, Chair. I'm also going to just go through it as the questions got asked, but I will ask the executive team to also respond to some of the questions. With regard to the questions from Honourable Member Clark, the Chair has responded to the issue around snakebite antivenom, and the requests that we have had, we put into a plan in order to look at improving production, but as the Chair has said, we have indicated the number of facilities, both public and private, as well as vet surgeries that have got antivenom in stock, and we will be putting out a communique because we've also got some stock available for emergencies. The process that must be used is that if a patient gets bitten, they must go to the nearest health facility. The patient should not be phoning us because they need to go, it needs to be administered by a doctor. Chair, also just to say, with regard to the issue around the article that came out with regard to the individual who could not access the antivenom, we were quite concerned when we saw that article, and we requested our communications section to contact the media in order to be able to guide the person as to where to go to get the antivenom. We were then told by the person who was contacted the patient had a dry bite, that the snake had not injected any venom into the individual, and the individual had been discharged. Now but we couldn't get the patient's name. It may have been a different patient, but all I'm saying is in appealing, if there is an individual, can we please just make sure the person goes to the facility? In Cape Town, we've got, for example, 40 facilities that have got snakebite antivenom. And over the next 2 to 3 weeks, we're looking at increasing the production and being able to sort out the requests for everyone who have asked for antivenom. And we will be putting out, there is a number that most people have available that they can contact, but we will make sure that that number goes out. The issue around the changing of service providers, I presume, Honorable Clerk, that you're talking about service providers for the courier services. Okay, so Chair, the courier services, in order to comply with the PFMA, needs to be renewed after the contract is expired. And the courier services was one of the contracts that had expired, and we had to go out on tender. There were delays, but we went out on tender. The award was duly awarded, and there were changes in the service providers. We did have criteria in order to look at empowering SMMEs with regard to that. There have been service challenges, there's no doubt about that. And that's something that we are actively addressing as newly appointed couriers. Our logistics services are working, and the area managers are working in order to overcome that. We will monitor that service performance very closely, because we have got contracts with these service providers, and we have said that we will be very strict on performance monitoring, because as part of our contract, we've got penalty clauses, etc. So we'll make sure that that service is adequate. We've put in measures into place where there have been service delivery problems, but I'm going to ask CFO to just expand with regard to that, the courier services. With regard to the timelines for accreditation, Ms. Babaki will respond to the issue around accreditation and the timelines. But as part of our APP, we have given you timelines as to how many facilities we're looking at. Let's just say, however, is that our performance is greater than the targets that we've had. And we're trying to accredit and push forward that accreditation as rapidly as possible. With regard to backlog for blood alcohol, and again, I presume the question was just on blood alcohol. Chair, we just to say that in Western Cape, we're putting in various measures in order to address this. Appointment of key critical staff, support staff, key analysts, management structures, etc., in order to sort out some of the issues in the forensic chemistry labs. We also requested that overtime is conducted in order to sort out the backlogs. In Western Cape, the blood alcohol backlogs have been sorted out. They worked overtime in order to sort out the previous ones. So the current number that we've got there is what has been received during the last month, and we're working with regard to that. The blood alcohol backlog in Durban has been sorted out as well. The challenge we have is in the Johannesburg area, as well as in Pretoria, and we're busy working, as I've indicated, We're looking at expanding or relocating the Pretoria lab so that we can have more space to sort that out. So we are working on that, and we will dramatically reduce the blood alcohol backlogs in these institutes. Our biggest challenge, as I've indicated, is the toxicology backlog. And we are meeting with the forensic pathology services, as well as the National Department of Health, during this week, in fact, and in order to, we have been meeting to work on plans, but we'll be having a sort of an even bigger meeting in order to sort out the backlogs there. So, Chair, with your indulgence, we'd like to report back when we next come to the portfolio committee, because we are committed to try to sort out the issues in the forensic chemistry labs. With regards to the issues around medical technicians and what happens after training, and the HR executive will respond to it. We are responsible for the placement of medical technologists, as well as the new category of workers called laboratory scientists, as well as medical interns. And we've been sitting with the universities of technology in order to look at, because the production of these students have been greater than the number of places that we've had accredited with the HPCSA. So we're sitting down in order to make sure that and we've also met with we've also asked the HPCSA for a meeting so that we can look at whether we can increase the number of accredited places, but also to work on a plan so that every single one of them will be placed. There was a challenge with the Tshwane University of Technology. We went beyond what our responsibilities are, where we personally spoke to the private sector in order to get everyone placed, and everyone was placed thereafter, except for 4 who opted to go to defer their placement. So we've been actively working with the private sector, the HPCSA, the universities of technologies, in order to look at the placement. The HR executive may want to add a bit more with regard to that. Member Gela, you spoke about the load shedding. We have indicated how it is affecting us, but we will be going all out in order to see how we can sort it out. The aging infrastructure, if it relates to IT, we've are now implementing and almost at the end of implementation of improving the MPLS, the multi-protocol layering system. That's our wide area networking, which improves our bandwidth. We've got a before and after. Our bandwidth has been dramatically improved. We're actively working with the service provider where there are problems, where cables get stolen, for example, where performance hasn't been great, in order to improve the performance in a number of those areas. The IT executive may want to speak with regards to that. With regard to the aging infrastructure, again, we are also looking at improving on the infrastructure by looking at new infrastructure, say, for example, for the forensic chemistry laboratories and certain of our laboratories. And we are going on modernizing equipment to get state-of-the-art equipment. And that, I can say the challenge has been, it hasn't been as fast as we would like, but we've issued a number of major tenders, and we're working continuously in order to improve that. The issue with regard to the non-payment of debt, the provinces had been paying quite well. I mean, last year there was a bit of a challenge, but we've had discussions with KZN, and we will follow up those discussions with regards to their old debt. Gauteng has paid off the majority of its old debt that was before 2016. They had a challenge last year, but we're continuously working with the provinces with regard to that in order to mitigate the risk, Member Gela, that you spoke about with the non-payment of the debt. So we're working with them on a continuous basis. Our cash flow, however, and when we report back to the portfolio committee on our audited financial statements, has improved. So provinces, even though they haven't been paying the full debt, are still paying towards the invoices. The conditional grants for from the NDOH, and for the NICD and the NIOH, we are raising this with the National Department and Treasury. The subsidy, we do subsidize both these entities to a great extent, and we continuously are presenting in order to advocate to the NDOH with regard to that. I've spoken about the challenges with regard to the forensic chemistry lab. We're working all out in order to address those challenges with regards to procurement, the infrastructure, the support staff, etc. And we are seeing some changes, but we'd like those changes to be much more rapid. The issue around NAPISA and the zero progress on NAPISA, can I just say that there is a task team that we have between the National Department of Health, the Medical Research Council, NICD and NIOH, in order to look at how do we fast track progress with regard to NAPISA. The NHLS is not responsible for the drafting of regulations. That has to come from the National Department of Health. And the National Department is the one who would be publishing the regulations on NAPISA. Chair, can I also just say that with regard to the issue around the turnaround time for the HIV PCR tests, what we've got in the document is targets, but they're not the actual achievements, because our actual achievements has been sort of different from that target. So in 2019-20, our HIV PCR, the audited target was 75%, that increased to 80% in 2020-2021, and then in 21-22, it went to 93%. So those were the actual achievements, not the target. Okay, we looked at the target and we thought that this was the most realistic one.
So maybe maybe I could just add in there, just for clarity, that remember that 21-22 figures and before were impacted by COVID. So we had these changes around COVID. And when the board approved the planned targets for 22-23, these would have been done at the beginning of 2022, and we were still in the middle of COVID and not quite sure where the direction exactly was going. So what you need to recognize is when you ask us about the drop to 82%, that was what we were planning under COVID conditions. It's not what we've achieved. And later in the year, when we come back and we present our annual report, you'll be able to see the 2022-23 audited figures, which is what we'll have achieved by the end of last month, as distinct to what we had planned for under the circumstances in January 2022.
Thanks. Chair, with regards to member Chewa's questions, and my apologies, the sound bite was not very clear. So if I haven't interpreted some of the questions, then just please correct me. The issue around the mobiles, and the funds that were spent with regard to that. So the mobiles were purchased during the COVID time. The proper procurement procedures were followed. The mobiles were procured correctly. And the mobiles were desperately needed for the community outreach program that needed to be done for COVID-19. If you recall, the private sector had what was called drive-throughs, because the private sector could have cars that could reach the population that they were serving. For the population that is dependent on the public sector, we needed to improve on the access. There was over 10 million people that were screened for COVID-19 using the mobile vehicles, and the mobile vehicles played a vital role during the opening of the borders, reaching a number of individuals in borders. They continue to be used for outreach programs to the communities for testing and screening for laboratory tests. They also have been used as depots in places where there's difficulties in providing services. So they still continue to play a vital role, and most importantly, they are also playing a role with the TB recovery program, the TUT. We work closely with the NGOs and the National Department of Health with regard to that, and the number of people plus the revenue from the tests that get done. The value for money has been well worth it, but more importantly, the access for the vulnerable communities has been extremely important. It was also able to reach a number of old age homes and a number of other facilities as well. The issue around, is it Zama Holdings? Sorry? Okay, so I'm going to ask the CFO to deal with that. I didn't quite get the question about increasing capacity. So Member Chewa, if you could just please repeat that question. The issue around in Port Seleka will be dealt with by the HR executive. We've got the import.
We were just using it as an example.
Yeah. So the HR executive will deal with that. Then we've dealt. Yeah, Member Kaba, I didn't quite get your question. Did you get this? Member Kaba. Okay, and Member Wilson, your issue around the NAPISA board, that's the responsibility of the National Department of Health. The regulations first have to be published on the composition of the board in order for the board to be appointed. And yeah, and I've spoken about the provinces. We're in continuous contact with them with regard to that in order for us to be able to mitigate the risk of non-payment going forward. The issue around accreditation of laboratories and who does it, the private sector has to do the accreditation of laboratories for the public sector, and the public sector does the accreditation of laboratories for the private sector. So that is a hampering factor for us, and we've had discussions with SANAS, because we're then dependent on how many people are available in order for us to We'd like to have a lot more facilities accredited, but we get hampered by the number of individuals that the private sector can send to us. And so that's something that we are discussing with SANES. So, and then your question on which forensic chemistry labs have we taken over? Just to say, the police services have got their own forensic services where they conduct forensic services in order to determine who was responsible for the crime. So that's a separate forensic service, and it's got nothing to do with us. Often the DNA testing and so the DNA testing often gets confused with us. We're not responsible for it. The police do that fingerprint testing and the DNA testing and the ballistics testing for the guns, etc. Then you've got the forensic pathology services, which is the mortuary services, where the post-mortems get done. That falls under the provincial departments of health. They don't fall under us. The forensic pathology services are the ones who determine the cause of death. They take tissue samples and specimen samples, and if they require chemistry to be done on it, that's what gets sent to us. So our forensic chemistry labs only do the blood alcohol, pre and post-mortem, and then the toxicology, the heavy metals and the chemistry, and then, as I said, food chemistry. So that's why part of the confusion is that a lot of things get laid at the door of the forensic chemistry labs when it isn't necessarily us that do it. Okay, so I hope that and then member Tebikayo, the issue I've dealt with the IT infrastructure. Mr. Shlongwane will add on all the various measures we're doing to modernize it. But just to say that with regard to clinics, we are not responsible for the information systems in clinics. So we're dependent on the National Department of Health. And then and that does, so we can only interface once the system is put into the clinics. And then with regard to the issues around POPI, the chair has dealt with it. We've dealt with this extensively. And just to say that we've been audited by the information regulator, we comply with POPI. They said that they will give us more information as to how we can improve with regard to that, and we're looking forward to that. So Chair, with regards to Dr. Jacobs, with regard to the turnaround times, we've got details of the turnaround times of every single test that we do once it gets to our laboratory, and we can give you details, and that's what we provide to all the hospitals. Some tests definitely take longer, and other tests are sort of much shorter, like all the chemistry tests. But we're pretty good with some of the tests, and we, where there is problems, we try to deal with it. We've been having problems in the Eastern Cape because of the electricity cuts in some of our facilities there. And we will report on that when we're reporting on our quarterly report. Yeah, but we actively monitor that. And the opportunities for advancement, the HR executive will deal with that. And then, Chair, we really, so really would like to thank you for taking up the issues of NICD and NIOH. And we just recommend that the portfolio committee makes a recommendation that Treasury should increase the conditional grant for the two institutions, as well as for our teaching, training and research grant, as well as for forensic chemistry labs. So we really would like you to take that up on our behalf. Thank you, Chair. Yeah,
thank you. This is a bit loud. Just on the issue of medical technologists and the placement thereof, I think you addressed it extensively. Just to add on it is we have another challenge that we also dealing with as part of our engagement with the institutions of higher learning and HPCSA, that we are now dealing with the transformation from the medical technology diploma into the now new Bachelor of Health Sciences, which requires us to change our program and our plan, but we are in engagements on that as the CEO has indicated, and we have already started taking the BHSC students into our system as part of their training. The other issue that was raised is around what have we done on racism, sexism, and also harassment. I think we started, we have a sort of three-leg approach to it. We started the gender-based violence awareness campaign last year, which we started around the time when Women's Day was approaching. It went through right up to the time when we normally have the national campaign around gender-based violence. And in there, we had both internal and external speakers that were creating more awareness around this, and also information around what needs to be done or what people can do in case they're faced with gender-based violence. We also acknowledge that it is not a once-off thing. It is something that we will need to keep on renewing as we go by, so that we are able to change the culture around gender-based violence, because we know that it extends beyond the workplace, also into the households. We also have in-house training where we conduct training around diversity management, and I think between January and to date, we have trained a little over 400 people within the NHLS, and it's an ongoing program that we are running. We're capitalizing on the virtual platforms to actually reach the masses, because we only at the moment have one resource that's doing it. We have quite positive feedback on it, and we believe that it will also contribute towards that. I think one of the other things is the zero tolerance approach that we have towards harassment, especially sexual harassment in the workplace, and we are implementing our policies in the areas of discipline to ensure that we deal with that decisively, and that it is something that the organization knows that it is not tolerated within the organization. I think with those three interventions, obviously, we will grow more interventions to ensure that at the end of the day, the culture within the organization displays the behaviors that are anti-racism and also harassment. On the issue of the accreditation of our training from an HR perspective, most of our training is actually SAHPRA accredited. In fact, it is one of the requirements that we use when we select our service providers, to ensure that at least our employees can use those qualifications elsewhere. I think it's also worth mentioning that a majority of our employees choose to do training that we call pivotal training, which is mostly training that is linked to university qualifications. So that goes without saying. In terms of how it benefits them, I think it's an issue of once somebody has a qualification that they can, that is in their name, they will obviously contribute to NHLS core competencies and strategic objectives, but also as part of our mandate is actually training, and it goes beyond the NHLS space. We have also noticed the loss of the skills into the private sector, but it is not the loss of skill to the country. I think that well, in some instances there are, but I think the question was mostly to medical technologists. So I hope I've answered the question on that.
So can I just emphasize that the NHLS holds very a strong stand against discrimination in any form based on any demographic profiles, whether it's gender, race, or whatever. And our values reflect our anti-racist, anti-sexist stand, and we'll make sure that that's not tolerated in the organization.
And I mean, I think, Chairperson, if, I mean, staff have been dismissed, staff have been disciplined around, for example, sexual harassment and any discriminatory practices. So, I mean, if members become aware through their channels of such allegations, then, you know, they either need to inform the CEO or encourage those persons to come to the CEO. We've just had a dismissal of a rather senior person quite recently around these kinds of issues. And so, you know, I mean, I think the position is very clear from the board and very clear from the executive management.
Thank you very much.
Well, okay, quickly.
Thank you very much, CEO. I'm going to be responding on the issue of accreditation of laboratories. And with regard to the turnaround time to accreditation, I think the CEO has alluded to that. There's different factors affecting the turnaround time, but we depend on our APP to set the targets for that year. And as we've alluded, the National Central Labs all have been accredited. The provisional tertiary, we are also doing well and hoping for 100% accreditation in 2024-25, and so are the regional labs. We are looking and putting proper, you know, intervention to enhance the accreditation of district labs, of which currently we are at 42, and we are looking at ways in which we can support the district labs, and including also using some of the virtual interventions, and also ensuring that, you know, we can mobilize some of the experts to support the laboratories. Thank you.
Thanks, Dr. King. The CFO will respond.
Okay, so thanks, CEO. So just to respond, so the CEO has already alluded to in terms of our contract management process, which basically speaks to the close monitoring of the performance of the service provider. So this would obviously extend to the courier services as well. But I just wanted to respond specifically to the issue raised on Zamlangeni. So with regard to Zamlangeni, there were issues when the service provider commenced with the services in September last year, but the region acted rapidly in terms of resolving the issues. And currently there are no issues with the service that's provided by the service provider. I've received confirmation from the area manager. And then I also wanted to just add to what the CEO alluded to in terms of what we are doing as NHLS in terms of our aging infrastructure. So in our demand plan, which we've submitted, we have included quite a number of projects in terms of renovations, which the regions are actively working on via the RFQs. And then from a head office perspective, we have got a number of bids that we have approved that are working on renovating our various labs. Thanks you.
Thanks, Chair, and afternoon, or it's still morning to the Portfolio Committee. On the 3 items around information systems, one is the information systems itself. In terms of our track care system, we were a decentralized system in terms of the environment, and we then centralized to track care, of which that's where our health record, historical health record has become solid. That's what then the CEO was referring to in terms of our IT systems being solid. That's one. In terms of the aged infrastructure or infrastructure, we are in the process. We have refreshed some of our environment and our data centers, but it's a very expensive exercise. So it is staged and stretched amongst financial years. We are doing much from the previous financial year, and we'll be doing quite a lot this year as well. We had to stagger it because of the capital expenditure associated to it. In terms of IT connectivity, which is the NHLS, the CE has talked to, we are at 90% rollout, of which now the hindrance is on the footprint of both fiber and microwave, where all the network cell phone companies don't have coverage on those particular areas of our labs. So the remainder of the 3% is based on that, where there's totally nothing, and the alternative, which is either LTE or other forms of satellite connectivity, is being explored. Lastly, which talks to the skill, HR exec talked on that. We are training our staff, and where we are getting external services, we are also getting training from those service providers, and we are minimizing outsourcing of services by when we get services, we also correlate that with training onto our internal staff. So that's how we are then upskilling our staff. And thanks, Chair.
Thank you very much. CEO, are you done?
Yes, thank you very much, Chair.
Thank you very much for the broad replies. Honorable Chirwa, 2 minutes. Thank you. I give you a second chance.
Thank you so much for your response. What I wanted to clarify in your reply about the insourcing issue was that I was not speaking broadly about insourcing. You might have missed it, because I did say that I noted the insourcing of cleaners and workers years back. You guys have said it also in the portfolio committee meeting. I was particularly asking about the delivery aspect of the NHLS in relation to the Zemlangeni holdings debacle. That why isn't the NHLS increasing capacity in relation to deliveries? Because there is a service that will always be done by the NHLS. And I was speaking. Pardon, sorry?
Continue on.
No,
we were just clarifying, sorry, that we understood now that you were asking about the insourcing of courier services, I think is the specific question.
Yes, that's the one I was asking about. And second to that, I take the response on the issue of racism and GBV. Thank you for your response. But I think there should be a level of awareness, especially on the Mposileka case, that we all should have in this room, because we've been talking about this issue for years now, right? And I always use it as a case to give also the NHLS a point to introspect on how they handled that case. Because for an example, where she actually lodged a complaint about racism and nobody dealt with that issue before the whole issue about her misconduct and everything else happened. She had cited the issue of racism of her senior manager and nobody took that up. So now you're speaking about a senior person having faced, you know, the processes of dealing with racism and all of that. And it's good. That's how it should be done from the get-go. And I'm happy that we are having that kind of awareness. But we must not sugarcoat on how this particular case was treated. And you sent me a response. We've been talking about it for years on end. I'm also in contact with Poseleka, and this had a very bad impact on her life. She can't move.
You have 3 minutes now.
Hey, we're going to have a problem. Hey, Chairperson, like, we're going
No,
to have a
you won't
serious
have a
problem
problem.
because
I'll have a problem with you.
we
I've
have
given
tried.
you, now you've taken 2 points.
No,
No,
you didn't give me time.
You wanted to speak
Can
about
you-
one
can you
point and
just-
you now
can
raised
you
two.
just-
Finish.
And I have
Please
a right to
finish.
do that. I have a right to do that.
No,
I can
I've given
speak
you
about
one
points I want to
opportunity.
speak about.
Honorable Kirwa,
Yes, but I can speak about
I
things.
said
I'm a
you
portfolio
before, you
committee
don't need
member of this
1,000 words
committee.
to say something in 10
Why
words.
should
Please
you always
finish.
be so provocative? Why can't you let me speak as a member of this
I'm going
portfolio
to have you
committee
removed
and
if you
allow
don't
me?
listen.
Of
Please
course,
wrap up.
I know that. I know that's how you function. That's how you
Yes.
function. You can't allow me to be a proper
Honorable
member of the
Kirwa,
portfolio
second
committee.
warning.
I'm
Please wrap
speaking
up.
about something that the NHLS is aware of, but you are throwing tantrums for no reason at all.
Honorable Kirwa, your
There's
third
no
warning.
need to throw the tantrum you're throwing. There's no need at all.
Ms. Majalamba,
Introspect.
please remove Honorable Kirwa.
Of course,
She's
but
3 warnings.
introspect. There was no need for doing
Thank
all
you.
of that.
And then
I want to engage the
NHLS must
CMS
please
as well,
reply
but
to
now
her
you're taking
question.
me out of a meeting that I have a right to be in for no reason at all. As a chairperson, you're
Honorable
throwing a
Kirwa.
tantrum because I asked a
Ms.
follow-up question.
Majalamba,
What is that?
We
What
respect
is
your
that,
leadership, Chair.
Chairperson? Why are you throwing a
please
tantrum because
remove
I'm asking
Honorable
a
Kirwa
follow-up
now
question?
from
When
this
you gave
platform.
me a platform, you said I can speak. You said I
gave
can
you
speak.
2 minutes. CEO, please reply yourself. You also have 2 minutes, you and Professor Book, to give that reply to what Honorable Kirwa raised.
So Chair, can I, with regards to the issue around insourcing of careers, this is an issue that we have at the BLRF, the Bargaining and Labor Relations Forum. And it has been something that the organized labor has put on about that they want us to insource all the career services. We've done an exercise looking at the cost effectiveness of that. It is part of the demands, and I would just suggest that we go through sort of due process with regard to that. Through the Bargaining and Labor Relations Forum. Chair, I also want to suggest that with regard to the case around in Poseleka, that Honorable Member Chewa has raised this previously. She's raised her concerns, and we took her concerns quite seriously, because the point that she was making, of the member being
Dr. Chetty, can I stop you there, please? Dr. Chetty,
Okay,
this has
so
come
Chair,
up
I want to
repeated.
suggest I put it in writing.
Yes, this has come up repeatedly for the last year, and that's why I had to stop Honorable Chirwa. It's the same story coming up all the time. Please deal with this, write to her, put it in writing to whoever wants to get writing from you. Make sure you send that also to the Secretary of the Portfolio Committee. Thank you. And you need to do 2 other things also in writing for me. The FFC mentioned the shortage of doctors and specialists. Professor Book, yourself as the CEO of the CMSA, can you maybe just write to us? Tell us what is really happening, what is needed to be done, because surely that's the backbone, especially the doctors, the backbone with the nurses of the medical services. And then if you can, you said you were going to write to us a report on the backlogs of forensic chemistry labs. Please do make sure that you do that. And I think we are quite out of time now. I'm going to allow Professor Book maybe just to say last words for 10 seconds. Thank you, and we'll go to the next presentation.
Just to say thank you very much for the opportunity to present our annual performance plan. And, I think It's been, I think, very good for a number of our managers to be present today. So thank you for that opportunity, so that we widen the exposure. And as I've said before, we keep careful notes of all the inputs, and we feed back to the full board, and we look to address the issues that you've raised with us. So thank you very much.
Thank you very much. Honorable members.
May I say, sorry, Dr. Jacobs, I missed earlier when that's why I hesitated when I was introducing my fellow board members, because it was hard for me. We didn't have the list of names, but I just want to point out that the deputy chair of the board, Professor Jeffrey Mphahlele, has joined the meeting and has been with us, as has Professor Michael Sachs, who's the chairperson of our finance committee of the board. I hope I haven't missed any other board members from the chairpersons of our different board committees that are here. Thank you very much.
Thank you very much, Professor Buch and Dr. Chetty and your team. Thank you for coming to do this presentation. You have a bit of homework in terms of those reports, but we do appreciate this as the portfolio committee, and I look forward to your responses on the two which I had raised with you. Honorable members, just to remind you that this is a continuation of the meeting this morning, which was opened. We had given the rules. I had read through the rules. I'm going to always implement the rules. I was very careful to say, and very nice to say, 1 warning, 2 warnings, 3 warnings. Please let us respect the chairperson of this portfolio committee when there are particular rules given, and I would really appreciate your working well with me in this regard. I'm going to invite Dr. Sipho Kabane, who's the CEO of the Council for Medical Schemes. I'm also with him is the chairperson of the board, Dr. Makuwane was going to join later. I would see whether he's already joined. And then also the member of council, Dr. Kolane Kubene, and then other executive and senior management members. Dr. Kabane, I'm going to hand over to you. You can mention whether I had been right as to who has joined. The NHLS, you're welcome to stay on. You're also welcome to leave, just as a reminder. And then Dr. Kabane, over to you. And once you've done those introductions, unnecessary introductions, you can purely mention. You can go straight over to your presentation. Remember, you have 1.5 hours for presentation, questions and answers. Thank you.
All right, thank you, Honorable Chair. I don't know if you can see the presentation.
Yes, I'm just trying to, I said, don't think you have the presentation. I think that's your email. The email box.
Let me try once more, Chair, to just share with the. Is it visible now, Chair?
There you go. Just maybe put on slideshow, please. Thank you.
Right. Right, thank you, Honorable Chair and members. My name is Dr. Sipho Kabane, the Registrar and Chief Executive at the Council for Medical Schemes. Yes, Chair, our Chair is going to be joining in shortly, but we've got Dr. Ngobese, who's one of our council members as part of the audience. And I've got the executive team and senior managers that are part of the presentation. Chair, I will proceed with the presentation and the contents will really cover those areas, and I'm not going to list them. But the first area that I just wanted to touch on, Chair, is that yes, we are a creature of statute. We're brought into life by the Medical Schemes Act, and we've got policies that are linked to the National Department of Health as our executing authority. And on the right-hand side of your screen, you'll see basically the mandate that we carry, which is to protect the interest of members of schemes, control and coordinate the medical schemes industry in a manner that is complementary with national health policy. We're also expected to make recommendations to the minister on issues that relate to schemes, investigate complaints, settle disputes, and collect relevant information and make rules that are in line with the Act, and advise the minister on any matter that is in relation to the scheme's environment. But the minister can in turn direct us to address any matter as per his delegations. So our vision, Chair, is on the left-hand side, and our mission is on the right. And just to summarize it, Chair, it just talks about us ensuring that members of the public are informed of their rights and obligations, and that complaints are handled speedily, and that we make sure that the entities that we regulate comply with the Act, but we're also going and checking if schemes are actually managed and governed properly, while also advising the minister and collaborating with other regulators. I'm not going to go into details on that slide, Chair, but just to say that the two big things that we've been trying to do in this 5-year period is to make sure that we are an effective and an efficient regulator, and that we play a key role in the implementation of the NHI. What you see there as regulatory philosophy is how we approach our regulation by being transparent, fair, independent, equitable, consultative, cost-effective, firm, but proactive. And that's how we treat the entities that we regulate. These are just our values, Chair, and I'm sure members can have a look at them. But then this next slide actually talks to our 6 strategic goals that we've chosen for the 5-year period, which actually drive this current APP that we're presenting. And that's to improve the quality of services and reduce costs in private healthcare, encourage risk pooling, effective risk pooling, ensure that the entities that we regulate are compliant with the Act and regulations, become a more efficient regulator, and ensure that the policy directives and advice that we give are in line with the Act and are based on research. And yes, to collaborate with others in the work that we do. Chair and honorable members, this is just a snapshot of the entities that we regulate here. We are still sitting with 8.9 beneficiaries. Yes, there's a year-on-year marginal variation, but that membership has been stagnant for quite some time. We've got 72 schemes presently, and these are reducing in numbers through consolidation and mergers. And we also have, administrators that are increasing in numbers, the managed care organizations, the brokers and brokerages. But Chair and honorable members, the annual contribution that we all make to schemes on an annual basis stand at almost 200 billion per year. And out of that, 160 billion is paid in total benefits for what we require. 17 billion is used by schemes and administrators for non-healthcare expenditure. But we also have 32 billion, which is the out-of-pocket expenditure that we as members experience when schemes reject claims and certain items are not paid for. And it is an understatement because some of the monies that we pay privately are not shared, in terms of information with the schemes. So this is a major problem for us because we believe it, in an economic situation such as ours, it can cause improvisation and a great problem for members. The schemes collectively sit with 98 billion rands. And yes, our legal requirement for solvency sits at 25%, but the schemes collectively have an average of solvency of about 44.5. So as an organization, Chair, we think we've done fairly well, because over the years, we've exceeded the 80% performance against set targets. Our most recent performance was at 83%, and we have had unqualified audits since we were established. Now, the challenges that we are faced with here, and these are just not limited to what I'm projecting on the screen, but I've just taken a high level, turn to this year. So we've got this regulatory mandate that is forever stretching and is not matched by the funding levels. We've got high staff turnover. We've got an aging ICT infrastructure. We've got unstable continuous availability of power and internet connectivity. And we've got rising regulatory and compliance costs, whether these are inspections, curatorships, and basically, the directives that we give to schemes that lead to litigation. We're still sitting with the Section 59 investigation, whose final report is still not finalized, but I'm going to talk about this, Chair. There's also an introduction of unregulated products into the market and general non-compliance by schemes and regulated entities, which keeps us busy on a day-to-day basis. But in terms of our highlights, Chair, I think we have talked about our organizational performance, our unqualified audits. We have, over the past 2 years, improved our cash flow and financial health. And we are no longer in the red, and we've increased our policy and research outputs. We've significantly reduced our complaints adjudication backlog, and we've made significant progress in implementing, the new structure as per the restructuring. And we've also made significant progress with the prescribed minimum benefits review and the low-cost benefit option guidance framework. And there's been also good progress in coordinating fraud, waste, and abuse interventions within this industry that we regulate. So our focus areas for 2023-24 is to finalize the low-cost benefit option framework and present this together with recommendations to the Minister of Health, but to also ensure there's significant progress in the review of prescribed minimum benefits. We're hoping to finalize the Section 59 investigation and actually ensure that the panel releases that final report in this financial year. We want to accelerate, the industry fraud, waste, and abuse initiatives. We want to standardize the amendments of rules and schemes so that members can understand them better and not get caught up, in that information mismatch. We're also doing a lot of work developing our funding model. I think we've come to this committee and complained about our funding, but we also promised that we're going to revise our funding model. So we've started this work and we hope to accelerate it this year. Yes, we're going to collaborate with other local, regional, and international regulators. So, Chair, because of time constraints, I'm not going to take the panel through each specific definition of the outcomes. And I'm going to move directly, Chair, to slide number 25. And I think that will go straight into the discussion on the APP targets themselves. This slide that you see, Chair, is just meant to guide honorable members that when they are looking at the full document, they should be able to understand that what we're presenting mostly is sitting between pages 24 and 56 and pages 57 and 72 of that large document, because that's where the measuring of performance is actually dealt with, as well as the budget. But Chair, we've also put up a slide here that seeks to indicate what has changed, from the last APP to this one. And basically, we are saying that we've introduced 5 new indicators coming from last year, and that 19 indicators have been removed and relegated to our operational plans, because we thought we had too many operational indicators. But we've also changed 8 indicators, in finalizing our 2023 APP. So all in all, honorable members, we now have 59 indicators, and this is what I'm going to take the honorable members through here. Honorable Chair, this slide is just aimed at guiding members of the committee in terms of slides and the programs that I will be referring to in the presentation, so that there is no confusion as to where we are with the presentation. So basically, I'm going to address now from slide 27 up to slide 43. And Chair, with your permission, if I can just spend less time on those areas where the target is the same as the previous year, and maybe place more emphasis where there has been a change in an indicator, just so that we can explain why we have changed that indicator to look the way it does. But yes, this slide basically confirms the 59 indicators and that distribution of these indicators amongst the various programs. And yes, the slides on the side is just to say which slide we will be at here. So I'm going to start with program 1.1, which is the Office of the Registrar and CEO. And Chair, if I can just ask honorable members to focus on the green column, as well as the column on the left of it. The green column actually talks to the target for 2023. The column on the left of it is basically the target that was set for 2022. And those are the 2 columns that we wish honorable members to compare when they go through this, just to see if there were any changes. So Chair, like I proposed in this particular program, there have been no changes between 2022 and 2023. The targets remain the same, and there have been no major changes. And I will move on to the next one, which is subprogram 1.2, which is the Office of the CFO. And Chair, if you look at, again, the green column and the one on the left of it, you will also see that the targets are the same as they were for the previous year. So there has been no changes. Now, in this third slide, Chair, slide number 29, you'll actually see that in that first target output indicator 5.1, that relates to percentage of network uptime, which previously we had set at 99% and have failed, Chair, to achieve it because of load shedding and basically the unavailability of the networks. So that target has been revised downwards from 99 to 95 in order to accommodate all the challenges that load shedding as well as networks present to our operations. But otherwise, the rest of the indicators on that program and page remain the same. Subprogram 1.4, the corporate services, the first 2 indicators that we've projected on the screen, you'll see, Chair, there's a change on output indicator 7.1. And this part of the subprogram relates to legal advisory services. Previously, we had set our target at 90%, and we believe that we've built sufficient efficiencies to raise the target to 95%. Otherwise, there are no changes on the rest of the page. This program, this next slide, Chair, honorable members, talks to HR, and you will see that the change in the target relates to output 9.2, and this is where it relates to the turnaround in the employment of people at CMS once a post gets vacant. Previously, we had set that turnaround time at 120 days. We have now reduced that to 90 days. And again, Chair, this is based on the internal efficiencies that have been developed. In the next set of indicators, these relate basically to just internal processes like performance agreements, assessments, as well as the office utilization. And the targets remain the same as they were in 2022. So there has not been much change in that area. In the next set of indicators, we have a change, and this is an output that relates to a collaboration with stakeholders. And we believe that we need to increase our engagement with stakeholders, and we also need to make sure that people are aware of what CMS is and what it does. So we've increased those two, the first two indicators, the first one from 30 to 35 in terms of number of activities. The second one, we've talked to awareness in terms of percentage, and we've increased that to 65%. The next set of indicators, Chair, relate to the work that is done by the Council Secretariat, and most of the indicators on that in that particular program are either new, or if we have retained them, we have not changed the targets. So there isn't much to be said on those indicators. In the next set of indicators, there are changes. The first one relates to declaration of financial interest, which in the previous year we had set at 100%, but it became difficult to get hold of some of the members for one reason or the other, and we missed the deadlines. So we've reduced that to 90%. And then the next one relates to the publication of appeals. You know, once rulings have been made. Previously, we didn't take into account that after these rulings have been made, there are certain processes that need to be engaged with before the publication. So that new adjustment is to accommodate those processes. This program 2, Chair, only has new indicators, and those that were reflected in the previous year have not changed. So I will also move on it. This next program is part of our core business, which is regulation. And you'll see, Chairperson and honorable members, the indicators on this page have not changed from 2022 to 2023. We've retained them as they are. And then continuing with the regulator, you'll also see that one of the major changes in this slide is that last output indicator 22.1, where in the previous, there's actually no change there. I beg your pardon. All of these indicators are the same. I nearly made a mistake referring to 2021. But those indicators have been retained as they are, honorable Chair and members. And then continuing with a regulation on this particular slide, there is that change on that output indicator 23.1 that makes reference to governance interventions. And again, this is an indicator that we had set at 100%. But now, after recognizing that there are certain processes that need to be undertaken before the finalization of that process, we have revised this down to accommodate those processes that we have now uncovered through a process mapping and analysis. The same thing applies to the output indicator 24.3. We had also set it at 100%, but we realized we're not fully in control of that process because we need feedback from the affected parties. So basically, we've revised down our target to 80%. In terms of policy and research, program 4, the targets that we've set for 2023 are exactly the same as those of 2022, 2023. So there's no change there, Chairperson. And continuing with policy, research and monitoring, there's a slight change in that first output indicator 27.1, which we had at 10 as a target in 2022. Now we've revised it to 5. And this change, Honorable Chair and members, is because this target of 10 has now been split between 2 programs. So only 5 of the targets will be performed by this unit, and the other 5 have been transferred to the clinical advisory services. And we will make a reference to that at the relevant time. The rest of the indicators have not changed from the previous year. This slide talks to program 5, honorable members. It's about member protection. And yes, there are adjustments in some of those indicators, in particular, number of stakeholder education and training. We had a target of 50 in the previous year. Now we've increased it to 55 for the same reason that I mentioned earlier on. We need to reach as many members of the public as well as scheme beneficiaries and be able to explain how this industry works so that they are able to engage with their schemes much more intelligent. The other changes sit with output indicator 30.1, where we've also increased the adjudication of complaints within 120 calendar days from a target of 75 to 80%. This is also as a result of the efficiency gains that we've made. We're able to process these complaints adjudication quicker and within a shorter time span. So we believe we can take more, but the rest of the indicators remain the same. This is still also around member protection and basically, when you look at the indicators for 2022 and 2023, there are absolutely no changes. So these were proceeded with in the way they are. So Chair, that takes care of the targets that we have set for our APP. Like I said, we now have 59 indicators and basically these are spread around the different programs and we're hoping to achieve these at the end of the financial year. This slide, Chair, just talks to a conversation that we've been having regularly with the portfolio committee, where we were asking, we're answering the question, what are we doing to, address the issue of youth unemployment? And those are just the statistics of, the current situation at the CMS. We've got 7 youth on fixed-term contracts. Internships in numbers are 11, and in total, there's 18 of these. Honorable Chair and members, the next part of the presentation will be taken over by my colleague, Andy Sazinja, who's our Chief Financial Officer. Thank you very much, Chair. And over to you, CFO.
Thanks, Register. Good afternoon, Honorable Chair, Honorable Members. Register, are you going to project or should I?
I can stop sharing.
Oh, no, I'm unable to. But if you're going to manage the slides for me.
Okay, I can continue to manage the slides for you.
Okay. Thanks, Register. I'm going to present the budget for the 2023-24 financial year. It's just a few slides, honorable members. How we've prepared the budget for the new financial year, we've linked it to our organogram and also our planned performance for the year. As the honorable committee is aware, most of our budget is based on levies that we received from principal members of schemes. We have proposed a levy increase for the new financial year of 5.7%. That increase is based on the then projected CPI for the new financial year from the Reserve Bank. Over and above that, we've asked for a R1 once-off increase only for the 2023 financial year, which will fall off in the next financial year, which is 2024-25 financial year. The reason for that R1 once-off increase that we've asked for is to fund our ICT requirements. We have aging ICT infrastructure. We've been experiencing quite significant ICT challenges as CMS, and therefore we have proposed for that R1 once-off increase just to fund those pressures so are able to stabilize again as the organization. We are still waiting for the approval of our proposed levy increase. Department of Health and National Treasury, they are still considering it, as the response must be in concurrence between the two ministers. We have also proposed for a levy, a tariff increase of 4.23%. Over and above levies, we also charge tariffs in terms of our regulations. Our tariffs have not been increased or only been increased once since our existence over 20 years. We submitted a proposal to increase the tariffs just by 4.23%. That is still being considered by the Minister of Health. If we can move to the next slide, Dr. Kabane. The next slide, please, Dr. Kabane. Now, the next slide just gives a mental picture of the levy trend over the years that we've been charging as CMS. So this is just a once-off. Members pay just principal members through the schemes just once off in a financial year. So this is just gives you a graph of how much we've been charging per financial year. You'd see here between 2022-23 financial year moving to 2023-24 financial year, there's a jump of about R3. That's because of the 5.7 inflationary link jump and that R1 once off, which will fall away when we move to the 2024 and 2025 financial year. So the increases over the years have been based on CPI and are also based on our operational requirements. The next slide, Dr. Kabane. Now moving to slide 49, only focusing still on our revenue as CMS. That's where we get our revenue from as the organization. Most of our revenue comes from the levies. We're planning to collect R193 million in this new financial year on levies, assuming that our proposed levy increase is approved. Much of our revenue also comes from the accreditation fees that we charge, and also a little bit that we get from the government grant we get from the NDOH. However, over 90% of our revenue flows directly from the levies. The next slide, Dr. Kabane. Now, comparing the 2 years, 2022-23 and 2023-24, the economic classification, this is CMS's overall budget. Over these 2 years, our budget has moved from 194 million in the 2022-23 financial year and to 210 million in the 2023-24 financial year. That's an increase of 8%. Now, going into the line items within that or classification, the COE classification, the honorable members will see that there's an increase of 12%. I'll focus on the big increases, and the CAPEX change is an increase of 140%. I'll talk more to this in the next slides, but just to give a high level view of why we have these increases. Mainly on COE, it's influenced by the cost of living adjustment that we factored into account. the impact of benchmarking that I'll talk to in the next slides, and also new positions that we budgeted for in the new financial year. The registrar has spoken about the new organogram that we have and us phasing in certain positions in terms of the new organogram, as we can't afford all of them all at once. So this is part of that phasing in of those positions in that organogram. Also, I've spoken a bit about our ICT issues or challenges that we've had. Hence now there's some increase in terms of the CapEx, in terms of the ICT plans that the unit has, moving to 140% of the CapEx. Some of the amount is catered for under goods and services that will be required for this ICT investments. Overall, if you look at our budget as a percent, or if you look at our COE or goods and services as a percentage of budget, as the organization, we strive to ensure that we keep COE within 65% of our budget, so that we are able to fund other priority areas within CMS. It is a difficult one to manage. Slide 51, Dr. Kabane. Slide 51 shows just in a graphical picture what I've just spoken to from last year moving into the year that we are presenting as CMS, that our goods and services, there's been a slight jump there, and also a slight decrease there. And also CapEx is more or less the same, because in terms of the rent value, it's not too high. Slide 52, Dr. Kabane. Now to go into the detail, what influences COE? How we've budgeted for COE, we've budgeted it based on our CMS policies, obviously limited to affordability as allowed by the CMS policy. What we factored in for the new financial year, cost of living adjustments of 4.5% for executive and all other employees, 5.5%. It's important to note that we have not had discussions with the union and to be able to agree on the cost of living adjustment. This is simply what has been budgeted for, not what has been agreed with the CMS anyhow. Also, we've also included the provision for performance bonus, which is limited to 1.5% of our wage bill. This is in terms of a CMS policy. In terms of filling in positions or phasing in certain positions as per the new organogram, we've also budgeted for 5 new positions coming out of the new organogram for the new financial year. And lastly, during this process of coming with the new organogram, we had to go into a salary benchmarking exercise, and then the results of those have been received. Those are still being discussed by council. So to manage the risk, we've also included the impact of the benchmarking exercise within our budget for COE for this current financial year. So those are the key things that impact on the change within COE. Slide 53, Dr. Kabane. Now moving to goods and services, this shows goods and services in the 2022 financial year, 2022-23 financial year, moving to the new financial year. I'd just like to focus, honorable members, on the red highlighted items, which show significant either jump or decrease or a higher as a percentage of the overall goods and services for CMS. Obviously, the lease is one of our biggest expenditure, the building that we occupy, and so hence now you'll see it is the biggest cost driver for us as CMS within our goods and services. You would notice a significant jump under computer services. That significant jump is linked to the investment that we have planned for when it comes to ICT, ICT systems and ICT infrastructure. Hence now you'll see a significant jump. And then a slight decline when it comes to consultants, consultancy fees. What drives this line for CMS? The items that sit here, it's the appeal board fees, commissioned inspections, your PMB reviews, your internal audit fees. So those are the kind of things that sit there. And yes, there's been a decline. One of the positives when it comes to this decline in terms of consultancy is that we have slowly moved away from a number of investigations that were happening internally within CMS, which were also impacting this consultancy line. So there's been a decline in some investigations. Other ones of projects that we've had within CMS as well have fallen away, like your for the grading and benchmarking projects and so on. So now within consultants, there are those core items that we need to fund as CMS as part of our regulatory duties. And the last part is the legal fees. The honorable members are aware that we constantly have significant legal challenges as CMS, and we also have had significant labor matter related legal challenges. It has been quiet in the previous financial year, and this cost has been declining as well. Our legal team has been doing a lot of work where when there are legal matters that they need to consider, they sit, there's a panel internally that's been put together that considers all of these matters, whether it would be beneficial for CMS in the state to pursue these matters or not, instead of just taking every single matter that comes to CMS to court. So there is that sort of cost-benefit analysis that takes place before a matter is pursued further. So hence now you would see a certain drop there. The next slide, Dr. Kaban. The last two slides before I turn back to Dr. Kabane, honorable members, is just to show now CMS holistically, our budget per programs, and also I've spoken to our revenue collection here at the bottom on the slide. So these are all of our programs as CMS. The biggest noticeable jump, honorable members, in 2023-24 financial year is on information systems and knowledge management, which is our ICT investment that we've planned for in the current financial year. That is the biggest noticeable jump, as we need to invest in those systems. And in terms of our plan moving forward, it will be a once-off investment, but then we will absorb any other costs that comes with maintaining the systems that we have moving forward as CMS. And other big programs that we have corporate services, which is one of our big programs. The reason that program has a significant budget of 51 million, it's because it houses a number of sub-programs within one program. For example, sitting under corporate services is your HR, is your office management that has the list building, is your legal services that has your legal fees. So it houses a number of big programs within CMS. And another program that takes up a significant of CMS's budget is regulation. So regulation is the core of CMS, which talks to your accreditation, which talks to your compliance and so forth as the organization. Those are the programs that take up a significant amount of CMS's budget. The last slide, Dr. Kabane. No, this is the last slide that shows over the MTF, CMS goods and services compensation of employees there at the top, how much we had as a budget for 2021-22 financial year, 2022-23 moving forward. It just gives a nice round picture to the portfolio committee of how far we've come and where we're planning on going moving forward as CMS. And also just a little bit, a bit that I want to focus on right there at the bottom, the last two lines there at the bottom, when we're looking at the levies that we spoke to, just focus on the 2023-24 financial year. Yes, there is a significant jump of that 3.51 cents. However, moving into the 2024-25 financial year, the R1 will fall off that we're asking for. The R1 will fall off, and then the base will not be the 47.57 rand moving into the 2024-25 financial year. The base would be 47.57 rand less the R1 that we will calculate the proposed increase for the new financial year, which is 2024-25 on. So I think this slide here at the bottom just nicely shows the levies from the previous years and what we're anticipating moving forward. I think that is the last slide, honorable members. Thank you very much for your time. Over to you, Dr. Kabane.
Right, thank you, Chair, and honorable members. That's where our presentation ends. We'll be happy to take any questions.
Thank you very much, Dr. Kabane and the team. We appreciate your presentation here today. I'm going to take the hands of the honorable members, Gela, Clark, and Norton in that order. Anyone else, honorable members, to Makwayo? So it's Gela, Clark, Norton, Temba Kwayo. And Wilson. Anyone else? In that order, honorable members.
Thank you very much, Chair. Let me welcome the presentation from a Council of Medical Schemes. We welcome the indicators, the new indicators in the virus programs, as these are aimed at improving the work of the Council, and commend the scheme's clean audit report. The scheme generally has achieved most of its targets, and this is commendable, Chair, and should be continued. We are mindful of some of the limitations from the CMS, and in light of the agency linked to NHI will require some more strategic and innovation leadership from the team. Chair, my question to CMS, how is the CMS aim to reduce its legal fees? Secondly, can you please update us as a committee on any litigations the CMS is involved in? Thank you, Chair. Thank you, Dr. Kabani and your team for the presentation. We really appreciate the work that we are doing. Thank you, Chair.
Thank you. Thank you, Chairperson. Just a few questions. So sorry. And thank you for the presentation. Firstly, how much money would you need to fund all aspects of your operations? Then what are the specific sustainable funding model challenges? And what are the reasons for the high staff turnover, and how is this being addressed? When will key posts be filled, and what are the key vacancies? Then just in terms of, if you could just let us know, what is your progress in regard to the introduction of standardized low-cost medical aid packages and medical aids, and if this key performer will be affected, what impact would it have on the NHI? And then also, I'd like to know where CMS is on reviewing their PMBs. And can we please get an update on that matter? And then yesterday there was a slide in one of the presentations given to us in terms of the percentages of South Africans that are on medical aids. Can you confirm in raw numbers how many South Africans are currently on medical aids broken down into gender and race? So it'd be interesting to know. Thank you very much.
Honorable Dr. Nothnagel.
Thank you, Chairperson, and I would also like to say thank you to the presentation. Some of the questions, it covered what I also wanted to know, so I just want to ask, can the CMS reflect on what are some of the key issues stemming from the LCBO framework and highlight areas of intersection with the preparation for the NHI? And then I would also, just another question, want to know, the CMS should also report to the committee on what is the organizational restructuring process. Thank you very much.
Chair, we just missed that last part of that question. If the
Can you
honorable
repeat
member
that,
can
please,
just.
Honorable member.
Thank you. I'll repeat. The CMS should report, if possible, on the organizational restructuring process, if possible. Thank you.
Thank you, Honorable Dr. Temba Kwayo.
Thank you, Chairperson, and thanks for the presentation. I have two questions. The second one is it's a problem that I received from a certain couple, but I'll outline it. The first one is based on the output indicator 9.2, which talks to the average number of days to fill a vacancy. In brackets, it was stated that the turnaround time of 90 working days for each vacancy that exists during the year. And then followed by the exclusion of the position of the CEO and the executive. Please explain this exclusion and its turnaround time, the turnaround time of filling up the vacancy of the CEO and the executives respectively. The second question is based on a couple that presented their problem to me, and it needs your attention. It's a divorced couple that have one dependent, and all of them have registered their child in their respective medical aids. So what's happening is that the child is consulting through the mother's medical aid and has since birth never used the father's medical aid. So the mother's medical aid contacted her about the dual medical aid of the son, which are both active, which means there's somebody that is consulting on behalf of the child through the father's medical aid. So when he was contacted about this to say, is it possible for you to cancel the child from your medical aid since he is active in the mother's medical aid? He refused and said, no, that is the best way of supporting the child, knowing that what he was telling is not the truth, because he's sending another child on behalf of that child. So how can this problem be solved, and who can they contact about this issue? Thank you.
Thank you, Chairperson, and thank you to Dr. Kabani and your team for the presentation. I think principally the issues that I want to raise have already been discussed by colleagues speaking prior to me. So I'm left with just one query, and that is that in light of the cost of living increases, and we're talking about this across the board, it's fuel, it's food, it's electricity going up. The cost of living in South Africa is on an upward trend, and would appear in no time soon we'll be able to get that under control. And generally the first things that people cancel in times of financial stress, because they obviously want to keep the food on the table, keep children in schools, keep the cars on the road, etc., is insurances and medical aids. And given the cost of living escalations that we face at the moment, and I think we can all agree that's likely to continue for a while, how is this affecting medical aids? Because that's generally the one area where we start to see people cancelling that and their insurances. What we're also seeing, and I have children just entering into the work market and all of those kind of things, is that fewer and fewer companies are offering medical aids as a benefit, whether they pay a half of it, whether they pay a third of it, whether they pay anything of it. Fewer and fewer companies are offering this option, and this must be having a detrimental effect to the medical schemes as a whole, you guys as an entity, and it's obviously going to affect, I should imagine, private health sector more than anything else. Can you just give us some idea of what is trending? What are you seeing declines? Are fewer and fewer companies registering for medical aids? And how is that affecting you as a whole? Thank you.
Thank you very much, honorable members. Dr. Kabane, I have a few things I want to talk to you about. The one is on the increases which you had requested from the minister and which had been explained here to us. and the second one would be on fraud, waste, and abuse, and the third one would be on the PMBs. I think the last one would be on the section. Is it a section 59, if I remember correctly? It was just section 59 investigation, yes. So let me start with that one first. Maybe just for, we have spoken about this before, and maybe at some stage you said you will be moving towards the finalization of this. Maybe you should give us an idea of when do you think this would be completed and a report received on this matter. The second point is the request for increases in levies. Now, I can understand that you need an increase, that you need to increase your revenue generation. I can also understand that in terms of your mandate, that you need more money to come into your entity. My question would be, who would have to pay the levies? And you would understand also that I would ask it with regards to the surpluses which the medical aids have. If there's 4.23%, 5.7%, and the R1 once-off payment for the ICT has to come from the members, then it is quite a bit of money. If it is not, where does it really come from? Is that per member? And noting what has been said about the cost of living, the cost of fuel, the cost of electricity, cost of water, etc. So that is quite a bit of money. And is there an opportunity for you to direct this request more towards the surpluses, which we know had probably grown by at least 30 billion rand post-COVID, if not more, probably close to 40 billion rand, which are with the medical aids. And I would really hope you'll be able to answer this, and that we find a means that this should really come from the medical aids and not from the members themselves. Then you mentioned fraud, waste, and abuse. If you could maybe elaborate on your initiatives to deal with it, and other areas which the portfolio committee can assist with in this regard. It is a huge challenge in our country at the moment. It has been for a while such, and it really needs to be addressed very fast, and we are willing and able to assist you with this, with whichever recommendations you make. Whether it is doable for us, that's something else that we would decide upon, or whether it is correct. And then the finalization of the PMBs, I think it's quite important that this be done as expediently as possible. I'm hoping you'll also be able to give us at least an indication of a time frame for this. And I already mentioned the Section 59 investigation. So once again, thank you very much for coming to do this presentation to us. It's always very nice to listen to you, Dr. Kabane, and your team. And the members have raised a number of issues. We're looking forward to hearing your answers on these matters. Right, over to you. Thanks.
Right, thank you very much, Chair and honorable members, for those questions. Chair, I'll try and answer as many of these questions as possible. But like I earlier on indicated, that in the audience, I do have my executive team as well as some of my senior managers, and they will come in, you know, once I've covered the areas that I wanted to cover. Chair, let me start with the good news. I think in the previous engagement with this portfolio committee on Section 59, we were very frustrated as an organization, and we were contemplating taking legal action against the panel itself here. But following, you know, that appearance here, we've now been able to reestablish that communication channel with the Section 59 panel. And after, you know, protracted engagements, there's been agreement on all sides here that this work needs to be completed to an extent that the panel itself has presented a proposal to our own council with respect to what needs to be done to finally ensure that that final report gets released. And yes, there was feedback from our own council, in terms of the areas of unhappiness with that proposal, but they have mandated us as management to go and negotiate an agreed upon a project plan that is fully costed. And Chair, the good news is through those negotiations, we've now reached almost 95% agreement on the project and the budget. There's just one or two issues that need to be cleared, but I'm sure in the next few days, we'll be signing that agreement. And from what the panel has said here, is that if there's agreement, then they would start right away with the work, and that their intention would be to complete this in the shortest possible time,